Wonderful. I guess it's 3 o'clock, and as folks come in, we'll get started. Welcome everyone who is here, and welcome new as folks continue to join. I'm Alicia Frericks, and I'm President and CEO of Lutheran Services in America. And these are my favorite ways to spend my afternoon. I'm inspired by all the thought leaders and innovators that we see around the Zoom room today. So thanks for joining us. It's really a great example of how our community comes together across the country to share innovation and practice. And today we're launching a new format called part of our Strength and Service series called Swap Shop. And, these are opportunities to harness the power and potential of what we're doing across the country, working together and hearing directly from your peers. Today, our conversation is going to be focused on social determinants of health, which has a WHO definition of the conditions where people work, live, or play, but really those non-medical or traditionally non-medical services and supports that really have a direct correlation with health equity. And so we're going to be talking about the social determinants of health, their common threads across our network, and what we're doing in communities to address health equity. So we're going to hear from some insights from our members in a working group that we have, which is called the Enhanced Care Management Working Group. And I know Susan will put her name in the chat, and throughout the day today, if you really want to be more part of this conversation and work more closely with your peers, please let us know and we'll welcome you into this group. We're going to start by having a roundtable conversation with folks that are in the Enhanced Care Management Working Group and how they're closing those social determinants of health gaps in their communities. And I think you're going to see a variety of innovations and approaches. We're going to talk about how you shift culture to sort of think of your organizational culture to think about these things. We're going to talk about where does the business model fit into this innovation. And so really are excited to have all of the leaders here today. We're going to be joined, and I'll introduce them, but we're going to be joined by Amanda Kizwowski. And Amanda, I'm so sorry. I've known you a long time and never mastered your last name. My apologies. You can make sure that I get it right when we talk shortly here. She is from Director of Performance and Quality and Improvement at Lutheran Social Services of Wisconsin and Upper Michigan. Amanda Schroeder, we're also going to be joined by because we like the name Amanda here. And she's the Vice President for Home and Community-Based Services for Cross Lutheran Services in Toledo, Ohio. We'll also be joined by Matt Humidity, who joins us from LSS, Illinois, where he works as a network consultant with other community-based residential treatment providers. And we're hoping to be joined by Paul Greenwell, who's assistant to the Vice President of the Lutheran Family Services of Nebraska. And we're Rebecca Gallagher, who's Senior Director of Adolescent and Family Services at Family Health Centers at NYU Langone. So a great panel for us to talk with today, and really excited to hear what we can learn and share. And so I really invite you all to put any questions you may have as we start this conversation in the chat. Raise your hand, take your hand. You can, if you want to ask your question out loud, just feel free to raise your hand. We find these things work best when we can be as interactive as possible. So I'm going to start with Amanda, and let's see, if we've got all of our spotlights going on, but I think Amanda, we've decided that you'll kick us off here, and really wanted to see if you would be willing to really share the LSS Wisconsin journey on how you're addressing social determinants of health.
Thank you, and it's Kriskowski.
Oh my gosh, thank you.
Oh,
I'm going to practice
yes, it is a tricky one. I married into the name, was not born with it. So at LSS of Wisconsin, we really started our journey in looking into social determinants of health in 2018. And our first step was really starting by educating our senior leadership team to bring awareness of what are social determinants of health, build that common understanding, and then begin to have talks about how could we measure this and how could we start to move forward. So I'm going to share my screen with you all here briefly. There we go. You should be able to see it now. So we chose to use Healthy People used to be 2020 and now it's Healthy People 2030. And using their definition of what social determinants of health is. And this is, I believe, is a common definition used by quite a few organizations, but it's really those conditions within the environment that the people that we serve, what kind of conditions they live in that impact their health and functioning and just quality of life. And then going along with Healthy People 2030, these are the main categories. So we have 6 that we look at when we talk about what are social determinants of health. We look at economic stability, access to quality education, access to quality healthcare, neighborhood and physical environment, community and social context, and then food security. So these are the 6 that we use. And one of the things that was very important to us from the beginning is to really address and help people understand that addressing social determinants of health is addressing health equities within the communities and the people that we serve. And really recognizing that the National Institute of Health recognizes that the groups below really fall under those health disparities within the US. And those are all populations that we serve. So in just thinking about that and how we moved forward, we started by creating a screener and starting to measure at intake and then also at discharge where our families were when it came to these social determinants of health. Which ones do they continue to worry about? Which ones are big stressors in their lives? And we have found that the screener has been really useful at an individual level when we have providers and therapists working and using the screener to provide more understanding and insight to the stressors that those families are experiencing. At the program level, we have supervisors who will use this tool in their supervision with staff to kind of review where are they struggling, where are they doing a really good job, but also looking at the gaps within the services and where are community partnerships that we maybe need to start to build in order to meet some of these social determinants of health. And then at an agency level, really being able to look at what are those community needs and using that information for our strategic planning and moving forward and growth within our organization. So that has been part of our journey.
Wonderful. Any questions for Amanda before we continue? I have just a quick question for you, Amanda. Were you, what was the impetus? What was the motivation? What was there sort of something that brought this to mind? Call to action. What drove you all to really do this focus?
That's a good question. A lot of it, just some of the research that was coming out, social determinants of health was becoming more and more popular at that time within physical health centers. So looking at our hospitals and some of the clinics around us. And it really was the leadership of our CEO who said, this is something I want us to get into. It follows along with our mission, our vision, and having healthy communities. And I want to see what we can do to contribute to this larger community impact.
Wonderful. Well, thank you. Don't go away. We'll be right back. And now I'd like to turn our attention to Matt. Matt, as we mentioned, works for LSS of Illinois, which serves more than 40,000 people annually with services ranging from foster care, behavioral health, housing for seniors and people with developmental disabilities, and more. Matt, can you describe how addressing social determinants of health is really core to the LSSI mission?
Yes, thank you. And I was thinking of words to encapsulate how important this is, and I kept landing on it's significant. It's significant. And I'll explain. Social determinants of health, and this is literature based. Have a more significant collective impact on health and health outcomes than health behavior, healthcare, and the physical environment. And when you think about that, it's powerful statement that, especially for entities and organizations like those on this call that are working with vulnerable populations, this is your core focus. It's underlying and supporting your model. But before I get into some details, I just want to dissect the correlation between health equity, health disparities, and poor health outcomes, right? So health equity generally refers to, is an individual achieving their highest level of health and outcomes through the elimination of disparities. And that gets you to wonder, well, what are those disparities? And many of the domains that Amanda covered are exactly where we see disparities. But if there are many definitions, or I like the CDC definition for disparities, which says a disparity is a preventable difference in the burden, disease, violence, or opportunity to achieve optimal health. And what jumps out at me always is preventable, right? It's like, this is preventable and it's more important than the healthcare. And it's something that we've been doing collectively as a group, maybe not as formally as we've been doing it recently, since the beginning of social services and community-based delivery. Addressing vulnerable populations, addressing things like housing, economic opportunity, food stability, economic opportunity, have always been woven in the social services, but more recently, in the last few years, it really has been elevated to be something that is core and key. So for us, and this is true in health and medicine, we started seeing social determinants as not only something that is a prerequisite and a primer to produce a health outcome, but in addressing vulnerable populations, one of the most challenging barriers is earning the trust, engaging, and activating a person. And then there's no better way to do that and get a person woven into their treatment plan, participating and willing, than by addressing their social determinants of health. And it's the most human element of our work that we see, is saying, I know a preventative visit and a behavioral health visit are secondary. You want to know where you're sleeping and eating next. And I get why that's a prerequisite to the outcome. So we see it as a holding up our clinical model and allowing us to engage and activate individuals around their care. It's much more than we have to get this done. It is as core as it can be to producing those outcomes.
Wonderful. I want to take a quick pulse of the folks on the Zoom room before we go to our next presenter. Just either put in the chat or raise your hand. How many folks are sort of, their organizations already kind of focus on social determinants of health? Or think about at least one or more. Okay, great. Awesome. So this is great. And then looks like a lot of expertise here in the room. One more kind of question focused on that, or that you mentioned, Matt, is are you tying social determinants of health to health equity and looking at that? Just kind of raise your hand as we kind of get a pulse of kind of who's in the Zoom room here. Okay, great. So George Kaiser says Altair is great. And I think we're going to take a little bit of a deeper dive on the importance of tying social determinants of health to health equity and partnerships, and particularly LSS South Dakota. Wonderful. This is great. Okay. Any questions for Matt before we move on to our next panelist? And Matt's not going away either. So, keep the questions coming. So, Rebecca, you're with the Family Health Centers of NYU Langone. And, can you really share how you were, in your role, you're really looking at the connection between social determinants of health and health equity? Take that conversation that Matt started just a little bit deeper.
Absolutely. So one of the things as a federally qualified health center, it kind of goes in both directions. So I'll start on the healthcare side. We've integrated social determinants of health screening into clinical visits. So what that means is the SDOH tool is part of our electronic medical record, which is called EPIC. That's a system we use. And we've done different things. It depends on what works best in terms of workflow for a given site. So some sites, it's a patient filling in that SDOH screener on a tablet. In other cases, it's integrated into the nurse's workflow, and the nurse with all new patients at that site will do the screening and then make the referral. And in other cases, it's a doctor. So it depends on the site, what works best. But regardless of who is doing the screening, the next thing is that a patient is then asked, if a need is identified through that screening, would they like to be referred for assistance with whatever need was uncovered? And if the patient says yes, a referral is made to what we call family support services, which is our case management department. And then a counselor would reach out to that person who had an identified need. They would schedule them for an appointment. And let's pretend, for example, that food insecurity was the need. The counselor would then meet with that person, see if there are any other needs, which oftentimes there are, right? Just because they're referred for one need doesn't mean there aren't other needs. And then they might assist them in applying for SNAP or food stamps. They might connect them to our food pantry. And then, as I said, they might identify another need that they weren't even referred for, because once you start talking to someone, other needs come out. Maybe they need legal services, so that would be an external referral. Or maybe they're interested in English classes because they feel like that's what's preventing them from getting a job. Well, we have those in-house, so we would connect them to that. So it depends on, the individual patient situation. But I think the benefit of doing that screening is, A, it informs the actual clinical care. So let's say if you're a doctor and you find out that your patient is homeless, they probably would not have told you if someone hadn't asked, right? And then that's going to change. Maybe you're going to give different medication. They don't have access to a refrigerator, for example. Or maybe if someone has diabetes and you're focusing on diet and thinking they're non-compliant because they didn't buy certain foods, when maybe it was a matter they couldn't afford those foods. So it really kind of changes what those conversations are between medical providers and patients. We also look at aggregate data to better understand what are some of the dominant needs in the community so we can direct resources accordingly, both in trying to get additional funding, but also thinking about, well, how can we build better programs, because so many people seem to be experiencing XYZ need. So it's been helpful on that end. And then most importantly, well, I don't know, most importantly, it's all important, right? But another positive is we're just identifying a lot more people with needs than we would have if we weren't proactively asking. And by identifying those needs, then we can assist people. And obviously not everyone can be assisted with every need, but you're going to be able to assist a lot more people if you know what those needs are. And it's also kind of creating a culture, like when we also have trained people who are asking these questions to make sure they're asking the questions in such a way that people understand a lot of people are struggling, right? Because you don't want someone to feel like if they're having a hard time affording food, they're the only ones. The reality is a lot of people are having a hard time, and making sure that patients understand that. And the feedback we've gotten when we've, followed up with patients is, I think it makes them feel that, that they're cared for, that someone is asking. And it's made clear that every single patient is being asked these questions, because you never want someone to feel like they're being singled out, or that people are making an assumption based on how they appear. Oh, they must be, having a hard time financially. So we wouldn't want that to be the impression. And a lot of patients we work with are low income, but certainly not all of them, but everyone has asked those questions. And I think they understand that. And I'll be quickly say, it also goes in the other direction. People come in for social services. We screen to see, are they interested in health services? And then if so, we connect them to our own health center.
Wonderful. One-stop shopping.
Yep.
There's a consistent theme, and I'm kind of curious. I'm going to go off script just for a second, but would love to. Everyone's talking about this assessment of the social determinants of health, and I think I'm just kind of curious as to if we can do a kind of a show of hands of, are you all, what type of assessments are you using? We can start with you, Rebecca. Are they, where do your assessments come from? What are the tools?
So the tool that we use, we call it the Epic SDOH tool.
Okay.
It's a tool that's embedded into the medical record, but we selected that tool because it's very comprehensive. You can also hide certain questions depending on the population. So some, for example, are only appropriate for pediatric population, but we wanted like a validated tool. We wanted one that was ideally didn't have to, like it's already in our electronic medical system. So that's why we built that tool. And we felt like it addressed all the major needs that we wanted to focus on.
Okay, wonderful. Others, either put in the chat or just speak out. That's one of the interesting parts about this conversation, right? Is there's different ways to do that assessment. Some are built into the tool. Like you said, some are driven by the payer reimbursement. Just curious, I'd love to actually just have everyone put in the chat if you're using a tool, what tool, or, what assessment. Doesn't have to be. Amanda, which,
assessment that we use, it's actually one that we created at the time that we started this. There weren't many that were focused on more of the mental health. It was very on physical health. So we did a lot of research and created our own, and have then worked with Marquette University to clean it up, and worked with some of their researchers in their psychology department to make the tool better. But we essentially created our own using research and using advice from other documents and some of what was out there for the hospital systems at the time.
Helpful. I see George Clauser also said they created their own, I guess as part of Altair. Hi, George. And Life Plan. And then Ashley says Rural Aging Action Network uses CMS as accountable healthcare or accountable health community screening tool. So I think, that's just kind of an interesting reality. It probably shows maybe the emerging kind of nature of addressing social determinants of health screening for them, and then that relationship to health equity. Any questions at this moment? All righty. So now I believe that we've kind of really talked about how the social determinants of health naturally sort of fit into the mission alignment of Lutheran organizations across the country, the health and human service providers, and the impact that those can make. Now we're really going to talk about, so what does that look like? What are the on the ground realities as you start to implement programs like this? And I think it was really helpful that Rebecca, you mentioned, the acceptance, or maybe it took a little bit of a time for acceptance for the recipients of the screening to sort of see a value in that. And I think we've also seen that sometimes there's a organizational culture shift when folks kind of introduce these. So Amanda, I think you were going to help kind of share some of your experience on changing the culture around the social determinants of health screening that's employee focused. And before you do that, I do want to recognize that Sharif put in the chat. They use the All Hands Health Network, provides a health assessment and closed loop referral system. So, I invite, if anyone wants to learn any more about any of these tools that are even spoken about or in the chat, just, let me or Susan know, or just reach directly out to folks here, because this is a chance to exchange information. Now I'll take a breath and let you answer, Amanda. So culturally.
Yeah, one of the things that we found, and I found just in talking with other social service agencies, is there's some misconceptions about social determinants of health. So looking at, we've had conversations with some that are like, well, that's a care coordination sort of thing. That's not what therapists do. That's not part of our mental health services that we provide. Or that if we don't provide that particular service, like food security, if our agency doesn't have a means for food security, then we don't have impact on that. So why would we measure it? And then, in some cases, we've heard at our organization, as well as others that I've worked with, that it's just extra work to start measuring this. So really what we needed to do is we needed to start shifting our perspectives and moving it forward. So a couple ways that we did that was first making connections to the work, listening to our staff and connecting it to the work where they didn't see the connection. So we started doing some more education and conversations, providing this information to leaders, but really having them look at how are these different social determinants of health factors related to those mental health factors that they are seeing, that they do talk about: depression, anxiety, substance use, low self-esteem, toxic stress, all of those things they do see within their umbrella. So now being able to look at how these social determinants of health connect. We've also been able to then look at just to dive in a little bit deeper to some of these, looking at the effects of poverty and mental health on poor housing conditions for our housing programs, looking at the impact of racial trauma and the EDI work that we're doing and how it affects mental health, and looking even at some of those protective factors that we try to build within our families and our children and the individuals we serve, and how those social factors, those social supports really do help with some of the social determinants of health factors as well. So the second thing that we did is connect it to kind of what we're already doing. So it doesn't feel like extra work. We're already doing this screening. So we provided our teams with a little bit more information on how we're using the data, because that's something that I think is also a misconception. You ask us to collect this data and then nothing ever gets done. So being able to show them how we are actually using it, and in our case, measuring how clients move from this always or often being a problem to this sometimes and never, and how do we shift clients as they start to see us from intake to discharge. Also being able to use the voices of our cheerleaders. So for those who are using it, who have found value in it, really highlighting their voice and providing this information to them, and giving maybe the staff that are struggling with it a little bit more new ideas and new thoughts on how they might be able to use it. And then that way it doesn't just come from leadership in the quality improvement department, but it's coming from their peers and their leaders. And then also looking at outside of the screener, how else can than what they're doing. So focusing on how it can be used during treatment planning and measuring the progress that is made, looking at stress responses and reducing stigma related to them. So having them kind of think in other areas. And then the third thing that we did is really asked others to reflect and then listen to their answers. So we asked our teams and our staff, especially those who were struggling with implementing, we asked them a few questions, and including what you see here on the screen, but asking them to reflect and think about what value they do see with LSS focusing on social determinants of health, and what insight they might hope to gain related to their own program or the clients that they see. And then how should we distribute this message to others? And then being able to really listen to what they have to say and taking that and using that as momentum to move forward. So yeah, those three things, really connecting their work, building off what we're already doing, and then being able to listen to the input that they have, is how we have started to shift the culture within our organization to really having everybody see the value in measuring the impact we have on social determinants.
Mhm. Wonderful. Any questions for Amanda? All right. And then Amanda Schroeder, I think you've also really thought about and recognized how the culture needs to change. And just one quick thing before we hop in with Amanda Schroeder is just a quick raise of hands. As you all have implemented these assessment tools in your organizations, have you kind of seen similar challenges, that there's a little bit of a runway for adoption within your organizations, or run into any challenges? Okay, so maybe we have the only two people who ran into challenges on our panel here, so we got the chance to learn from them. Amanda, I know you've really been working through this, and just share your experience and what you all learned and how you drove adoption
Sure.
in your organization.
So we implemented our model in our affordable housing sites. And one of the big struggles that we had is obviously what Amanda Kay said before myself, is just getting our staff comfortable with the culture change and understanding how it all fits together in their role in that puzzle piece. But then you also have your residents and their caregivers that we really struggled with. We just thought if we did letters, resident meetings, and even had our staff follow up one-on-one with our residents and potential caregivers as well, that educating them that way would disseminate the information, and they would just comply and give out additional information or whatever the case may be. And as we all know, that doesn't work. And we found that out the hard way. Not that the letters weren't informative and at least got the message out there originally. We also did several follow-up meetings, but what we found is our staff are key. That our staff build the trust with our residents. So our staff, where our service coordinators in our affordable housing sites are the ones implementing the program. The site managers or the property managers, however you term them in your organization, are also key in this process, and as are the maintenance staff. And if you have housekeeping staff as well, everyone plays a role. And what we found in this process of educating our residents and our caregivers is if there is a confusing message or a staff member gives the impression that I don't know why they're doing that and I don't know what the importance of it is, then it really tears down your program and shows a culture of siloism. And sometimes you get those residents and caregivers that like to capitalize on potential confusion and maybe misdirection at times. So what we did is really took a step back and we continued to educate our residents, but we educated all of our staff, not just our service coordinators, of our site managers, and how important it was whenever an individual and their caregivers come to tour our sites, that they're using their own observational assessment skills. Are they coming? All of our affordable housing sites are for individuals with 62 age and older, or those that have disabilities. So are they bringing children with them? How many are they bringing? Are we asking questions? Are you caregiving for these individuals during the day? Do they spend the night? I guess everyone has to understand their role and keep their eyes open. Maintenance, for example, our maintenance staff are in our residence units more than anyone else on our staff from an employment standpoint. So are our maintenance staff keeping their eyes and ears open? Are they seeing different changes in our residents? Are they communicating that? Are you giving them the tools to really force the staff to communicate? Because your residents will see those changes. They'll also see the unification of your staff, and then they'll also see how important it is for that communication to occur, because they will see services being delivered to them quickly, and the importance of it. And that's when their eyes will open and they'll understand why the culture shift, why the additional questions, why one comment that we always got from our residents and our caregivers is, I just was asked that in the nursing home or hospital. Are you guys selling? Is my independent living becoming a nursing home or an assisted living facility, whatever the case may be? So there's always that hesitation whenever there is a culture shift. So be prepared for it. But then also make sure everyone on the team that works in that environment every day understands their role and how it all fits together, much like Amanda Kay said. Because that's when your residents will truly trust the process and the culture change, and then also be willing to be an active participant in it too.
Wonderful. I see George has a question, and we're going to go right into business models, George, in just a minute. So that's a great question. Anything for Amanda on culture change? All right. I think Paul Greenwell, who's the Assistant Vice President of Lutheran Family Services in Nebraska, drew the short straw and is going to share about how sometimes plans have to change, is the way I understand it. And actually, not necessarily the short straw, but
No.
really how it sounds, that your best plans don't always work out as imagined, and that, through flexibility and creativity are really critical to responding to the success of the program. So just share a little bit of your journey with us, Paul. That would be great.
Sure. So LFS Nebraska came to this work group through the lens of meeting SDOH and behavioral health needs for aging adults. And so our original plan, and I don't recommend starting a brand new program right on the heels of a pandemic, but that's what we chose to do. But our whole idea was to walk into this space and remove barriers to accessing care. And we were going to do that by bringing the services to the people we wanted to serve. So we took those services to supported living environments. namely independent living and assisted living locations. And so we recognize the multitude of barriers that aging adults experience. So that's everything from attitudes and stigma relating to seeking mental health services or just human services in general. Sometimes that's comorbid medical conditions, making it accessing or participating in care more difficult. Sometimes it's simply finding a provider who's accessible. So that could be a problem with the cost of care. It could be a problem with transportation, or depending on a natural support system for transportation, or just a whole list of other possible barriers. So our idea was really simple, and that we're just going to bring the service to you. So we had staff who worked within supported living communities. We worked alongside the community staff. We consulted with the community staff, and our providers were available to individuals in the communities on a regular basis. But a very strange thing happened, or maybe it's that something very strange didn't happen. And that's that people weren't just knocking on our door asking for services. Just because we were there, just because we built it, didn't mean that people were automatically just going to start knocking on the door. So to our credit, I will say we weren't totally naive to this possibility. We're very aware of stigma and the resistance of people to simply ask for help. And so why wouldn't those same issues apply to older adults? In fact, most of that stigma, most of the research around it shows that it's even more powerful among aging adults and older adults. Our younger generations have probably latched more on to a greater willingness to ask for help, but that does not seem to have transitioned to our to older adults and aging adults. So all that to say is that it became really evident really quick that we're going to have to adjust course and find new ways of connecting with the individuals that we wanted to serve and provide services to. And so in that, we found an opportunity to learn, and what we learned, not surprisingly, was that relationships go a really long way to developing connection and trust. So instead of waiting behind a door with a shingle hung out there saying, therapy or human services, our providers started spending their time in the dining facility and in the recreation areas and in the common areas, just getting to know people and learning about their stories and their lives. And after a conversation or two, the providers would simply ask, would it be okay if I started checking with you on a more regular basis? Can I just come by and see how you're doing? Sometimes a nurse working with a resident would make a brief introduction, and that introduction would lead to a conversation, which could lead to more regular conversations. And so these appointments, we just simply started calling them check-ins. Hey, I'm just going to stop by and check in with you and see how you're doing. And again, strangely enough, through regular connection and the development of trusting relationships, it was found that people were sometimes more willing to engage, and they would start sharing, and you would find that people, like many of us, were struggling in one area of their life or another. And with aging adults, some areas of life may be more so than others, but we found out that they were struggling. And with this realization, this connection, people started becoming more willing and more ready to engage in the full scope of services that we had available. And sometimes that was counseling. Sometimes it was simply helping them connect with loved ones they hadn't talked to in a while. So redeveloping that natural support system. Maybe it's calling a sibling or a child who can maybe help with transportation. But as we've really looked at the sustainability of our program and talking to our partners, what's really been reassuring is that this small little change called a check-in has really become the kind of an essential element of how this program works. So, I don't know that anywhere in life you just hang up a shingle that says therapist ready and willing, and people don't just come knocking, but the ability for our staff to simply, work and live amongst these individuals and create relationships has been an essential element, and we're going to hold on to it, and we're going to find opportunities to sustain that part of our program. So that's the flexibility that we've had. Again, I don't recommend doing it in the midst of a pandemic, but strangely enough, there it is. Sometimes the simplest things are the most important. You're still muted. There you go.
Muted. Wonderful. So building trust and that piece of to support that ongoing engagement is really critical to that work. I think we're gonna any questions for Paul? I think we're now going to bring everyone onto the Zoom screen and really talk about that all important question, which is sustainability and funding, and how do we, what are the different ways that, this activity can be, supported. While it's widely recognized that social determinants of health drive equitable health outcomes, sometimes it's a little harder to connect the dots for payers and others. And George Clauser had a great question up there. Who's working on value-based payments? That could be one way of reimbursement for this work. But just wanted to open it up to the panel and just kind of maybe and please. Folks, ask questions, as you go on the Zoom room and everywhere. But let's do a show of hands. How many would you say your social determinant of health screening is financially viable, supported? Anyone going to raise their hand? Okay, so Rebecca, we're going to zoom in on her. And let's see.
I only said like somewhat because it's
you were the only hand I saw.
no, I just went like that because we're basically supporting it through grant funding now.
Okay.
It's limiting our ability to expand. So we're not actually screening all of our patients because we don't want to screen more people than we can assist. So that's why I went like that. So I'm very interested in learning of additional ways to make it sustainable. We're more kind of, doing some of that work, but not as much.
Okay. So I hear what you say, Rebecca, is you have a grant funded model that limits who you can screen and then who you can support. Do others have a grant funded model?
Well, this is George. Hello, everybody. And Alicia, it's great to see you. We started at Altair with a grant funded model about 7 years ago. And that certainly is where we cut our teeth on trying to link social determinant outcomes to some type of payment model that demonstrated value to the person and to the agency. We have since graduated, and I use that term because it really is a graduation, in that we now are working with 3 health agencies or payers in the state that recognize the social determinant value. And I might point out that our social determinants are all linked to health. So we no longer have any social determinants in our disability group that are not linked to health. And we found that to be the real key to establishing value-based payments with a number of the health entities. So not to get into too much detail, but all the way from our care coordinators working with group homes to have a better outcome on very specific tactics. And then we are paid by the health system to manage those tactics. One of my favorite one is assignment of a primary doctor is a big deal in Minnesota. We have a high percentage of people claiming ED, emergency department, as their primary doctor. So we have made almost a 40% improvement out of 42,000 people with disabilities to move their primary doc to an actual person with disability competencies, and our providers have been paid based on that. I'd love to hear how others are thinking about that transition, and I'm happy to come back and speak more about value-based and how we are seeing the future around the country and how we need to bring it down to making it happen. Even if we have a disability lens or if we have a health lens, I really feel strongly that this is the future.
George, I have a quick question. When you say your social determinants of health are all linked to health, do you mean they're linked to outcomes that the health care system wants to see, like the physician visits?
Yes.
Mhm.
Yeah.
Okay.
Yes, that's probably better
Mhm.
said.
No, it's just a clarifying question.
Yep.
Mhm. Wonderful. Matt, I'm
Yes.
sure
Oh, yeah, I was itching.
you're a
No.
soulmate with George on that, I
No,
think.
George, good to hear your voice and see you. You know, we've, and that is true of graduation, so congratulations. You know, we've had success a few years back creating bundled rates where housing, food, and communication elements were woven in for a limited period of time. Because ultimately our MCO partners here in Illinois would say, look, you've got TANF, SNAP, low-income housing, other opportunities. We're not going to sign, and this was not an easy negotiation. We're not going to sign up to pay for these things, but we were dealing with a high-risk BH population, a small group of individuals who did not have housing, and other critical elements that directly correlated to the crisis and the presentation they were having. And we successfully said, okay, this person has MHSA needs and needs housing, and we were able to create a bundled rate. That was a good contract for us, not so great for them, because at the end of the day, you know, they were like, whoa, we counted all this up. You guys did really well. But we did save them, you know, in terms of outcomes. But they said, oh, we want to revisit the approach. And we started talking about codes, and that stalled somewhere between, you know, meetings with the very large organizations. And most recently, you know, we've always woven, you know, you hear braiding and blending funding, right? Donative dollars, grant dollars, and other dollars to try to make these realities. But we don't see a huge appetite right now for creating value-based contracts, performance-based contracts around social determinants, because the general motto that we're hearing is, no, we want you to connect them to services and you can bill for that case management, which we do. But the gap there, and I'd love, you know, that I think we need permanent funding on is, I can get somebody signed up for a program that the state offers, whether it's related to housing, which takes a long time, food, which takes time, not as long as housing, or other services, but what's going to fill that gap? And I'm really hoping that, I know there has been some interesting conversation. I know, Amanda, you've tried it. Amanda asked, you've tried it, you know, Z codes or name the code, but I think ultimately, you know, in a fully capitated model, George, it's great. You know, I think what you're doing is outstanding, but as some of us kind of, you know, get to that point in the world of value, I think that the immediate thing we're seeing is how do everyone says, if you don't have housing, you're gonna have a poor health outcome. But it takes me a certain period of time to get somebody lined up because of the waiting lists and the stock that are out there. So who fills that gap? And I'm hoping we can, and what we've done is create some really strong vignettes out of our ER crisis locations that says, Matt presented, he's been in the hospital 12 times. We gave him housing, it cost X. He's now not presented. The total cost of care savings is $100,000, or, you know, a 10-to-1 return on investment, to really help drive some of those discussions with MCOs. But sadly, I have to say, in the last, especially year and a half, maybe it was COVID that did this, a lot of the value-based conversations that were percolating a few years back kind of quieted down. I don't know if that's what everyone else thought.
Well, Matt, I hear you, and I think it's probably worthy of some deeper discussion. It does require the state to have a commitment and a path, but I wouldn't rule out the health systems. And, you know, we have two types of health systems. We have the corporate managed care, and then we have the nonprofit managed care. As you can probably appreciate, we're putting our focus on the nonprofit managed care, although I must tell you that every day the corporate managed care is knocking at our door aggressively. trying to intervene with a better approach to this. And, at some point, and I know Illinois isn't there yet, but at some point we're going to have to listen to what that means. Pennsylvania is in a straddle position right now. I'm going out to NASD tomorrow to hear more about what some of these models are evolving to, and we need to watch and learn. I mean, Iowa was totally transformed to corporate managed care under a value-based model. People are so happy, meaning not so happy. So it may have saved millions of dollars, but what did it do for the person and the agency? So, there's a lot of things to be weighed, and it really gets down to aligning with the state and seeing what their 5-year, 10-year goals are.
I have one question that
As you know.
Yes, sir. Yes, sir.
that
Well said.
surfaced that's related to this, and and I'd love to hear like the Amandas and Rebecca and Paul and both Matt and George weigh in on this as well. So what's the data? You talked about the vignettes, Matt, and I know, are you, as you guys are doing this grant funded work, are you collecting, can you talk about your data agenda or data journey to really try and contribute to that broader body of evidence that heightens that correlation between lower cost and better outcomes?
I'll briefly, it's a painful journey because data is impossibly siloed and fragmented, but we have workarounds to wrangle the data, and part of it's the state's involvement, part of it's the MCO's involvement, and have only been able to do that not on a population level, because that analytics is really more robust. We need to think about planning for that, but doing it on a literally, the last 2 vignette case studies we did were 8 patients altogether, 4 and 4, and we took a 2-year look back as to utilization history after housing and other social determinants were met. It's called Housing Connections, similar to Housing for Health and similar programs. And then we track the trajectory over the next year, and hopefully 2 years we stay connected with the person to show what the return on investment was ultimately for my actuaries, whether you're profit or not profit. Someone's interested in that. In that we spent X on housing. And by the way, the money we got in that program, the housing money came from a foundation, didn't come from an MCO, right? We had to blend it, but showed that, we saved for 4 people hundreds of thousands of dollars in avoidable ER and inpatient presentations. And ultimately the human story was so powerful, that you had somebody presenting in an ER with maybe some substance use and anxiety, and when you drill down deeper, it was really everything that was going on outside of their health that was causing that. And then we have some really true generative results where I can tell you one hospital I'm thinking of, 2 of the individuals that were in that program are now working at that hospital, right? And it's just so powerful to see. We just scale it. We need some of George Clauser's methodology because it works. The return, and I've always said this since managed care, since the whole bubble of everyone being covered by an MCO. This is the first time actuaries and social workers and healthcare professionals, everybody lines up, because if you do all this stuff, the outcomes that everyone wants are achieved. Right. You save money, you help the person, it's more of a human story, they're living their full potential, and the doctors are happy because they're getting that preventative visit and they're assigned to a patient as their PCP.
Great, wonderful. Okay, we got 6 minutes left. A real parting word from our panelists. I'll start with you, Amanda. As you look forward, what's your hope for this year in this work?
For us at LSS, we're going to be taking a deeper dive, and we're actually hoping to get a few research grants to help us with that. So really being able to demonstrate and show how our social determinants of health data correlates next to some of our other assessment tools like reduction in depression and anxiety and those sorts of things, and really being able to show that they are handled.
Wonderful. Paul, what's your vision for the next year and your hopes?
For us this next year, it's going to be about developing these partnerships and relationships more, I don't want to say formally, just more closely. so that we really can start looking at data from obviously the community side. So the nursing side, the medical side, and aligning that with the work that we're doing. So I think doing that through relationship and through data is going to be our next step. This has really been, the last 18 months has been a kind of a first effort for us to really formalize some things. Again, don't start things during a pandemic, but I think we're really getting to a place where we have some things that we can put together and share.
Awesome. Amanda Schroeder.
So for Jenacross, it's again, partnerships, like Paul said, looking for more housing providers to roll out the model and really prove the model, and also looking for those payers to really capture their attention with our data, start sharing some claims data so we can really prove out the true cost savings, because we're going off of estimates at this point in time whenever we talk about cost savings to a payer. And yeah, continuing to serve as many housing residents as possible.
Awesome. And Rebecca.
I would say one hope is that we'll start using this platform called Unite Us, which would enable us to make referrals to external organizations, but it'd be like a closed loop referral. So then we'll find out if they accepted the referral. Because right now, as I mentioned, we're kind of at capacity for our own department of counselors that are addressing all the needs, and that's not really sustainable. So that's why we're looking into this other option, and we'll see how that goes.
Wonderful. And Matt, closing words?
Oh, we're going to continue evolving our model and looking for partners and collecting data, and hopefully working with this group and others to from a policy perspective, a big picture perspective, and on the ground perspective, just keep advancing this. We're excited about creating some sustainability. We just need to do more work.
Great. And I think we'll continue in the working group that you're at, in our broader LSA effort to really grow our collective capacity to lead and affect this change that we know we need to see across the work that we do. So thank you all for your time today. Any last questions from the rest of the Zoom room as we've got the panelists here? Wonderful. Well, we've got 2 minutes to spare. I would invite you to look at our strength and service. Kim's got it up here. We've got a couple more webinars scheduled already, so I'd love to see you there. And there'll be a recording, and Kim will share that and other, I think, the PowerPoints that Amanda pulled together as well. So thank you all for spending your time with us this afternoon and for all the work that you do. And we look forward to seeing more of you in the next series or so. Take care. Bye-bye.
Bye-bye.